there are definitely a lot of good tools out there for you guys to use. I'm assuming everybody gets ultrasounds and also thyroglobulin measurements. And every once in a while, we'll get a CT scan, MRI. Dotatate is a nuclear medicine scan that is very, very important as well. So ultrasounds are the standard of care. Everyone else outside of thyroid world thinks ultrasound is very low tech, but in fact, it probably is the best at looking for thyroid lymph nodes and thyroid cancer deposits. It's not invasive. There's no radiation. It's everywhere. Like it's ubiquitous. You don't really need to, go to a special place for a dotatate scan, for instance. But it is operator dependent. If you don't have if you have a radiologist who does like maybe some ultrasounds of the liver and ultrasounds of the breast, and then every once in a while goes up to the neck, they're not going to be as detailed or as knowledgeable as someone who is focused on that. And this is where it comes down to many places. Many recommendations is to try to go to a place that does a lot of these, because the institution, when they do a lot of these, they're forced to become experts in something. When they have too many thyroid ultrasounds to do, they can't. They'll find someone to focus on it rather than do a little bit of everything, if that makes sense. It doesn't really look well for trachea or extranodal extension, and you can't really see deep, really far deep into these areas in the retropharynx or the retrotrachea. Thyroglobulin, we have a love-hate relationship with it. You guys, obviously, it seems like it's helpful. It's really the most sensitive biomarker available, but it has major caveats. If the thyroglobulin antibody is positive, then it's kind of a less useful test, because the antibody kind of makes things noisy. It's also confounded if the surgeon left any normal thyroid tissue behind, because then you don't know if is it coming from normal thyroid or is it coming from cancer. About 1/3 of thyroid cancers don't make it. It's weird. They're very aggressive. Yours probably doesn't make thyroglobulin, right? Yeah. And the way to think about it is it's so ugly, it's so deformed that it's forgotten the ability to make thyroglobulin, right? Whereas a normal thyroid gland is going to know how to make it. So usually it's the aggressive subtypes that don't make it, right? So sometimes you have like cancer all out the wazoo, and it's the thyroglobulin is 0 when you have a recurrence, and it's because it forgot how to make it, right? So it's not the best marker in that sense. However, if it's low and stable, it's generally considered safe to monitor. It sounds like that's your situation. And then a rising calcitonin for you, right? And a rising thyroglobulin, like doubling time, et cetera, like calcitonin, is a sign that the cancer is starting to grow. A CT, we like it a lot as surgeons. It can cover areas that the ultrasound can't otherwise get to. It's very sensitive for lung metastases that obviously ultrasound can't get through the ribs to get to the lung. But there is radiation. It has a radiation of 1.2 millisieverts, which is about the amount of background radiation you get in 5 months. So not a lot, but it is meaningful. Some doctors, I'm not a huge fan of this. They don't like the radiation from a CAT scan, so they want to do an MRI. It's generally considered inferior. It's second line. It's good for maybe looking at the esophagus, but really, how often does the thyroid cancer go into the esophagus? And it's good for looking at brain metastases. But in spite of the good thing of it not having radiation exposure, it has very reduced sensitivity for looking for small disease, right? Which in many cases, that's what we're hunting for, right? If the thyroglobulin is rising, where is it, right? We don't want to use a substandard evaluation. So ultrasound and CT tend to be the advantages. There's whole body scans. This was used a lot back in the day. It was a primary role in surveillance. But as I mentioned before, they don't make thyroglobulin. 1/3 of them don't. And so 1/3 of them don't concentrate iodine either. It just forgot, or it lost the ability. So I'm sure your anaplastic cancer, for instance, they don't do whole body scans. They don't even bother, right? Yeah, they just use like CAT scans. Right. PET CT is good because it looks at activity. So if it's a very active cancer, then it'll light up because it consumes sugar. That's the tracer that they use. However, it seems to able to detect tumors that are iodine negative. And then using the combination of whole body scan and PET CT seems to detect almost all cancers. It has a high false negative rate. What that means is if something lights up, it could be anything. It's not a very smart scan, right? Like if something lights up, it could be cancer, but it could be because you have a cold. Could be because you got a COVID shot and you had a little reactive lymph node. It could be because they punched you in the neck, right? All sorts of reasons. And that's why you really need to take a PET CT with a grain of salt. All right. Does that make sense? I think people sometimes get very amped up about PET CTs, but Yeah. So this is a key takeaway, especially for recurrence. Yeah, like when people read the report, they don't know you. They don't know that you have something in your back and then it's just a little, mole or something. Um, right. So these radiologists, they will say things, and sometimes they're not aware of what it might mean to you. Right. Oh, they think it's cancer. But I think what I'm trying to say is, in the end, radiologists, they're sitting in a dark room. They've never met you before. They don't know your history and all the other things that are going on with your spine. And ultimately, what they're looking at is pixels, right? It's pixels. It's not true cancer. It's just looking something on a screen that may translate to cancer, but it could translate to something else. So that brings me to the kind of the more gold standard, which is an FNA or needle biopsy. You other than in contrast to pixels on a screen, a needle biopsy gets tissue or cells in order to get a clear answer, right? Is it cancer or is it not? So if you have something like that on your spine or somewhere else that lights up on a scan, an FNA is usually the next step to confirm what it is. So for thyroid cancer, and this is very important for recurrences, because there are a lot of things that could be just noise, and we try not to biopsy small lymph nodes, right? Because many lymph nodes that are that size, they could just be reactive or just normal, right? They could be cancer, but they could also be normal. So therefore, our guidelines say that anything that is biopsyable should reach at least 8 millimeters in the central neck or more than 10 millimeters in the lateral neck before we act, before we attack you with a needle and try to get some tissue. Anything smaller than that, even if it makes you really worried, we try to steer you clear of it, because otherwise we'll be biopsying a lot of things that would otherwise not be useful, if that makes sense. And where do we get this number 8? Where do we get this number 10? It is a little arbitrary. It's somebody, a bunch of old wise men locked in a room and writing together some kind of guideline. But now you kind of understand why they're saying it. They're just trying to avoid causing unnecessary worry, biopsying everything under the sun for something that may not really be that useful. Now, there is something increasingly people use called washout, or thyroglobulin washout. And that's because a lot of thyroid cancers, they're like water balloons. They're lymph nodes, but they're just full of fluid. And the fluid doesn't have the cells that can clinch thyroid cancer. But if you take the fluid and then you wash it out and rinse it and then send it for thyroglobulin, if that thyroglobulin is positive, then that's definitely thyroid cancer, if that makes sense. Because what is thyroglobulin doing in a lymph node? It can only be cancer. Thyroglobulin should only be found in thyroid glands, right? Anyway, so in those cases, there's no cancer cells, but they're rich in thyroglobulin. And this really helps when you're dealing with a very cystic node. These are the situations where then we would think about doing surgery. I do want to tell you a quick story about where ultrasound is better, where CT is better. I had a patient, she was 37, she had a 3 centimeter papillary thyroid cancer. Her husband he owned an imaging center, right? He's very proud of his MRI machine, very proud, right? He's like, oh, I can find anything. I spent a lot of money on it. He got an MRI for his wife, and he said, look, the report says there's no abnormal lymph nodes seen. We're good, doc. We're just going to do a little thyroidectomy and be done. But then when we did the ultrasound, the MRI missed this 9 millimeter level 2 lymph node and then the biopsy showed cancer. So what this means is, even if you have the best imaging center on the planet, right? Even if you have all the resources at your disposal, certain scans are just not very good for finding this kind of cancer. In contrast, and then when we did surgery, just like in your case, the 8 out of 32, there were 5 lymph nodes that the MRI completely missed. So again, just to know that the CT and the MRI don't really, and the ultrasound too missed 4 of them. It just shows that there's a lot of microscopic disease out there. Then you have to just take out the neighbors, not just the target node. On the other hand, large disease really helps us when the ultrasound may undercall it. So when you have an 8 centimeter cancer, an ultrasound's kind of, it's almost like bringing a knife to a gunfight, right? Like, it's not enough, right? This is the ultrasound of a patient of mine who had huge bulky cancer. You can see it from across the room. And so you get this gobbledygook report from the ultrasound. I mean, I don't even want to read it. But then when you get the CT, look at that, right? There's like all this disease. It probably reminded you of your disease. Look at all this, right? There are bulky, large nodes. And what does that tell us? Well, when there's large nodes, it means that we probably have to use a bigger incision, right? And probably a higher incision in order to kind of get out there. We'd have to do that hockey stick incision that you had, ma'am, back there, right? It shows that this patient had tracheal deviation, right? So I have to make sure that maybe the trachea is involved, and that requires a different kind of operation. it looked like that it was starting to extend down into the chest. So now I have to get the chest surgeons around just to be sure, on standby to make sure. And then it's hard to see here, but this is the jugular vein, the jugular. And then on the other side, you can see that it's completely engulfed. You can't even see it. So we probably have to sacrifice that jugular vein. And so that's another important consideration, where this is where an ultrasound just doesn't do the patient justice. You have to have a CT. So that's why sometimes you'll see doctors do one or the other or both. And it's because for these particular reasons.